Our very first Palat Med Colorado meeting for 2026. Let's see, we have a couple announcements to start with, including our partners from CDPHE and CHCA. But why don't we start with Dr. Rebecca Jackson, our organization's vice president, and she's going to remind us about this upcoming annual conference in April.
All right, it is. It's that time of year, and we are getting prepared for our annual conference. It's our 31st, and I don't know, Ian, if you wanted to show, I think we have a banner already to promote everything. We're going to be talking about visionary goals and inspiring leadership at this conference this year. So we are saving the date for April 24th. It's at our usual location at the PPA Center, and so we're hoping that you guys will be able to join us in person. We'd love to see everyone in our community there. We also are going to be offering a live stream option, though, however, because we really want, to make sure we're reaching out to our rural communities and that we are, making it available to as many people as possible. So that will be an option if you aren't able to join us in person. But we are hoping to look forward to seeing you there. And we are going to be opening the registration. It's going to be on our website at cmda.us. And we are wrapping up our accreditation. We're starting that process, and we'll be kind of releasing our educational agenda, which it's going to be a great year. So jam-packed as usual. So we look forward to seeing you all.
You want to tell people how to register? Registration?
Yes. Yeah, it's on our website, which I will, hopefully everybody has that, but I will definitely drop it into the chat. You can just navigate to our website, and there should be a link there that you can register. Is there any other details that I'm forgetting? It's a great time of year. We always look forward to seeing everyone. As somebody who doesn't work in the Denver area, I really enjoy being there in person with everyone and seeing my colleagues. So.
Thank you.
Yeah, thank you, Sam.
Excited too. I know we are all working really hard to set this conference up. Well, it looks like we have our representatives from CHCA and CDPHE. Jenny, welcome. Happy New Year. Would you like to start?
Oh, sure.
Thank you.
You bet. I am going to share just a couple of brief slides because I want to show you some images. Okay. Just a quick note here, they're still in draft format for a infectious disease reporting reference sheet that we can use for our IP nurses in the SNF setting. They've created this for different settings, but this one encapsulates all of the SNFs as well as other providers. They have a separate one for labs. And I wanted you to be aware that they have actually taken a lot of stakeholder feedback and modified this to make it more user-friendly. This is an image of what it actually looks like, meant to be blown up as a wall chart. And I've listed here the immediate reportables, pending results. Most things are going to be reported by labs and not us directly, since we don't technically do the diagnosis. So it's going to be a rare thing that we directly report an infection, but of course outbreaks, suspected disease is where that's going to fall. So I thought you might want to be aware that that is out there and just about ready for broad circulation. I can send you a draft if you don't already have access to it, but it will be effective 2026. And then just a couple of other quick notes, not much this morning. Many of us struggle with vaccine hesitancy issues now, especially probably now more than ever. So ACA has created YouTube-based videos for us to use that are about 5-minute blurbs. They're very quick and easy. You just click on this slide and it'll populate it. It's not member only. You can pull it up. Anybody can pull it up. And each of these comes with facilitator guides to help people learn how to use motivational interviewing and other techniques that help people respond to these discussions more openly and positively. So I thought that might be useful for medical directors. And then I I believe I don't have much else to show you except for upcoming training opportunities. And I wanted to just mention the one that is coming up most urgently, January 13th, a sexuality and dementia training is being hosted here by a lawyer who's been part of CMS regulatory revisions and whatnot over the years and has a lot of knowledge of how to balance safety and rights. So I am excited to help host that training, but I will not be teaching it. I'll just be there as a heckler, and I welcome all of you to join me. Thank you.
Thank you, Jenny. Is information about that training just on the CHCA calendar?
I'm going to put it into the chat so that you have a quick access.
Appreciate it. Thanks. Good luck with that. Hello, Chad. Welcome to our meeting.
Hi, can you hear me?
Yes, we can.
I always have to check. Great. I had just a couple things, and then I think Joe had something she wanted to add as well. But I just wanted the group to know that, and this really isn't new, but we've been asked, based on an audit, an OIG audit, to fortify our licensure activities. So those things that we do for in determining compliance with state licensure requirements, that we need to fortify that. And so what you're going to see is that for complaint surveys in your facilities, there will be a licensure component and a certification component to that visit. They'll be integrated together. This would not pertain to facility reported incidents, but it does pertain to other complaints. And we also have an ability then based on let's say the standard surveys, so the recertification, relicensure survey, to extend the survey cycle up to 3 years, or utilize a tier system if the facility has been licensed for at least 3 years. There's been no enforcement activity within 3 years prior to the survey date. So this would be citations of harm or higher. No pattern of deficient practice within 3 years prior to the survey date, and no substantiated complaint resulting in significant deficiencies within the last 3 years. So then based on that, did want to make sure that you knew that with respect to our survey schedule, since we are able to extend as far as 3 years, we're also going to look at the schedule and expand that. So about a third of the facilities that we go out and do a standard survey will have the integrated licensure and certification survey conducted at the same time. So this will be something that everybody will have within the next 3 years. And in order to do that, we are looking at either one, assigning the primary responsibility for the licensure survey to one surveyor, or to add a surveyor, depending on the size of the facility, to conduct the licensure portion of our visit. And we're going to do everything we can to integrate that, meaning facilities should not experience an interview from the surveyor responsible for licensure and an interview from a surveyor who's doing a certification investigation over the same thing. There shouldn't be 2 interviews. We should be able to integrate that. Now, what it will mean is that there will be 2 deficiency lists, one from state and one from federal, that will require 2 plans of corrections. There's a crosswalk. So a number of requirements under licensure are also requirements under certification. So basically, your response is going to end up being the same. So, we'll probably see some cutting and pasting there. The other thing that I want you to be aware of is that with licensure and licensure only, this doesn't pertain to certification, but under licensure, if it's a low-level deficiency and does not involve abuse, The facility will have and low level meaning it didn't have harm, or that it's going to potentially cause harm. That a low level deficiency can be corrected prior to survey exit, and it would not be on the deficiency list other than to be. It's a 999 tag. It's an informational tag, saying the facility was notified of this, the facility corrected it, and there's no further action needed. So you'll find that these are going to be our survey practices moving into the future. We're going to do everything we can not to create a greater burden on the team, which means we don't want teams to be in the facility any longer in order to complete this additional licensure work. But we definitely want to make sure that we limit as much as possible the impact or the effect that this would have on the facility and its milieu.
Thank you for that big update. Yeah. Are there questions for Chad or Jenny or Rebecca? Dr. Rogers is asking if we meet the criteria, we would not be reviewed from 3 years from our last.
That is correct for standard surveys.
For state licensure surveys.
Yes.
And Chad, I know you at the roundtable, you talked about the QMP, the Quality Management Program. Can you just clarify for this group and for me, whether this will be expected to be a separate program from our QAPI?
So I have some background on that. So a few years ago, every nursing home had to submit a quality management plan to us at the department for review, and we have to keep those on file. So it's that plan. So they already have those plans developed, and they just need to review those plans and make sure they meet the state requirements for that. And those state requirements are in Chapter 2.
And there are a few things different with the quality management plan when you compare that to the QAPI or quality assurance plan required under federal regulations. So in practice, they're somewhat similar. They're actually very similar, but there are some details that are different, and we would have to, if you had them integrated in some fashion, we would have to account for the requirements of state licensure, as Joe said, under Chapter 2, and what's required under 865, 867, 868 under the federal regulations.
Anything else?
And Singh, I would just like to say something quickly about the CMP program, if I may. So I want to make sure that everyone knows that CMS has changed some of their rules and guidance for use of CMP money. They now want states to match their CMP funds with some of the CMP funds to provide opportunities and money available to individuals to receive RN and LPN training and education. So they have been pushing that program for about a year. They are finalizing the criteria for that. And in Colorado, our CMP funds are also dispersed under state statute. And so we have to change our state statute in order for these funds to be used to provide the funding for RN and LPN education. And so we are preparing what we can to hopefully get this put before the legislature this year. during this legislative session and looking for bill sponsors and gearing up for that. So that will be a wonderful thing if we can spend some of our CMP funds to help educate and provide more RNs and LPNs for nursing homes. So these folks would have to commit to working in a nursing home for 3 years in order not to have to pay back any of the funding that help that they've received, tuition reimbursement and stipends. So it looks like a good program going forth. And so do want to know that is on the radar, and hopefully we can get this passed this year so we can open up and create more opportunities for nursing homes with RNs and LPNs. So thank you.
Thank you. It would be a good way to spend that money.
For sure.
Right. Well, our next speaker is an associate clinical professor of glaucoma in the ophthalmology department at the University of Michigan. And Amy and I have known each other since before we even became physicians. And she is actually married to my brother, so she is my sister-in-law. I'm very pleased to introduce you all to Dr. Amy Zhang. She's going to talk to us about glaucoma medications in nursing home patients, efficacy and safety considerations for geriatricians.
Thank you, Dr. Palat, for this opportunity. I'm excited to get started. So we'll see if my slides are working. Let me know if you cannot view these. Can everyone see that?
No, they're not showing yet.
Oh, let me hit the share button again and see if we can.
You did it before.
I know, we even practiced. Can you see anything now?
It's coming up. Yep. It's
There
just
you go.
Yeah. I'll put in presenter view, slideshow. Okay. Since Dr. Palat had already talked about my title, I'll move on to my financial disclosures slide. I have no relevant disclosures regarding this topic. Just to give a little bit of overview, I'm going to talk a little bit about the epidemiology of glaucoma, then move on to classes of glaucoma medications. We'll talk about staff education and monitoring and clinical pearls for geriatricians. And finally, hopefully some take-home messages that we can, or the relevant pearls related to this talk. With regards to glaucoma, it is the leading cause of irreversible blindness worldwide. And what is interesting is that a lot of our eye diseases, including glaucoma, the prevalence increases with age. Specifically for glaucoma, the prevalence actually doubles every decade after age 40. And why are we talking about this? So primary open angle glaucoma significantly impacts quality of life in elderly patients, primarily through vision loss, as well as activity limitations. But glaucoma is a disease of the optic nerve. And so the optic nerve is what connects the eyes to the brain. And so when that connection is severed or damaged, our vision is limited. These are, the image on your left are some of the visual field deficits that patients with glaucoma may experience. It is not necessarily that their vision is completely gone. Early in disease, it tends to be more peripheral, but at the very end of disease, they do have a very narrow tunnel of vision. In a study done in JAMA Ophthalmology that looked at falls fractures, in individuals, specifically the elderly, with cataract, age-related macular degeneration, and glaucoma, they found an incidence of increased falls in all three cohorts. I've just highlighted some of the data in the glaucoma cohort specifically. And what they found was that elderly individuals with glaucoma have a significantly increased risk of falls compared to age-matched controls, with an adjusted hazard ratio about 1.38. And you can see where the primary sites of the falls or the secondary outcomes of the fracture sites are also highlighted. So it is really important that we try to preserve the vision for all of our patients, and especially those that have glaucoma. Why is this relevant or important for nursing homes? Because a lot of our patients who may be in nursing homes depend on their intraocular pressure control through management of eye drops. And the only known modifiable risk factor is actually lowering of intraocular pressure. There is not a lot that is known about how to regenerate the optic nerve, but we do know that lowering the intraocular pressure does slow disease progression and also helps to preserve quality of life. And visual impairment, as we talked about before, definitely leads to increased falls and morbidity. So moving on to some of the common classes of glaucoma drops that you may see that your patients are on. I've kind of started with the most common and then finally concluding with some combination agents. The numbers that you see in the parentheses highlight the dosing pattern or how many times a day these topical drops are used. Some of these medications are available in systemic formulations as well, and I'll try to point those out. So the first class is the prostaglandin analogs, and we're talking about latanoprost, travoprost, bimatoprost. The ocular side effects include conjunctiva hyperemia, iris pigment changes, eyelash growth. I think the most important to highlight of these is the conjunctiva hyperemia, and you may notice that in terms of redness. Just to indicate, not all redness suggests eye infection. So if a patient has recently been started on a glaucoma agent, that may be another reason why their eyes are more red than they were before, not necessarily that they have an ongoing infection. One nice part about the prostaglandin analogs is that there are rarely any systemic side effects and generally well tolerated. Another nice point is that it's only once a day dosing. So we recommend prostaglandin analogs to be used at bedtime or nighttime. It's not really specific to bedtime. I know that many of us write it QHS for and then or sometimes write bedtime, but it's more so that this agent works better in the evening. So you can dose it with some of the other medications that the patient may be taking, and doesn't have to be right before bed. There's nothing magical about going to sleep and this medication working a little bit better with that. So the next class of agents are the beta blockers, and specifically some examples include timolol, betaxolol. The ocular side effects include discomfort, dry eyes. You might notice a little bit of hyperemia, but ocularly, these medications are actually pretty well tolerated. However, with beta blockers, there are more systemic effects, such as bradycardia, hypotension, bronchospasm, and you certainly want to avoid these in cardiac or respiratory disease. And it's important to monitor vitals, especially if you see a change in how the patient is doing. You may want to review some of the topical agents that they're on. When else to avoid this? Just in case, if your ophthalmologist or optometrist colleagues forget these pearls, please be mindful of these things that I'm sure many of you already know, but this is something that we try to point out. You know, you want to check and make sure the patient doesn't have any pre-existing cardiac conditions, those who are taking quinidine or a calcium antagonist, patients who are asthmatic, or any patients with bronchospasm requiring inhaled steroids. I do have to say there's one caveat. If they're fairly mild asthmatics that are really well controlled and really haven't had any recent exacerbations, that may be okay, but certainly we do try our best to avoid it if possible. And of course, patients that have myasthenia gravis, as beta blockers have been shown to exacerbate those symptoms. So we're going to then talk about carbonic anhydrase inhibitors, and these include dorzolamide, brinzolamide. The ocular side effects of these medications tend to be pretty severe, and I would say that this class and the next class I'm not going to talk about are really the offending agents for conjunctivitis, allergic conjunctivitis. And if you look at the picture on your right, you can see there are actual little patches, and these are follicles. And so when we're examining the bulbar conjunctiva, the tarsal conjunctiva, specifically this is the bulbar conjunctiva, what you're noticing is areas of these little white sort of papules that you're seeing. These are follicles. And why is that relevant or important? Because to us as ophthalmologists, this would highlight that perhaps there's a drug intolerance or a drug sensitivity. And then the other part is that contact dermatitis in this sense also occurs. And you can see this patient has really, really red eyes that are pretty painful to look at. So once again, just to think that perhaps it's related to medications rather than an infection would be important. Some of the systemic side effects include malaise, fatigue. Very rarely, there are severe reactions such as Stevens-Johnson. These are definitely more likely with systemic carbonic anhydrase inhibitors such as methacrylamide and dorzolamide. We tend to reserve the systemic, or we tend to reserve the oral agents for very uncontrolled intraocular pressures. We don't routinely put our patients on oral carbonic anhydrase inhibitors, but in rare cases where the intraocular pressure is just beyond control and the patient's not a candidate for surgical intervention, there are times that we do prescribe these agents, and sometimes for longer term than just 1 week or a few weeks. It's important to monitor for any altered mental status, and because some of the systemic carbonic anhydrase inhibitors do have some sulfa moieties, it's important to ask about any sulfa allergies for the patient. All right, so we're moving on to our next class. This class is also very much responsible for the allergic conjunctivitis that I talked about, as well as burning and stinging. So if we try to avoid these classes as much as possible, given the ocular side effects. Oftentimes, patient will complain that the drop stings. Actually, all classes of our drops sting. There's no eye drop that we give, maybe except for artificial tears that don't sting. So that is very common. And the stinging and burning may or may not get better over time. But definitely, if you start seeing the allergic dermatitis around the eyes, it's important to notify us so that we're aware to stop prescribing this medication and to document that as a true allergy. The systemic effects include sedation, hypotension, dry mouth. So it's very important to watch for increased falls, drowsiness, confusion in patients that have been started or have been on these and developed these symptoms. What's really exciting is for our field of glaucoma is that we've had a new class of medications. This came out in the last 5 years, and we're talking about Rho kinase inhibitors. So Rho kinase inhibitors, the only available one commercially in the market in the US is natarzodone, or otherwise known as Rhopressa. The ocular side effects is actually fairly well tolerated. There's a little bit of conjunctival hyperemia, of course, the burning that is noted at the installation site. But the systemic effects are rare, maybe occasional mild headache, but otherwise fairly well controlled. And it is nice because it's, once again, that once-a-day dosing. Some of the combination agents that are available in the United States include Cosopt, which is a combination of dorzolamide and timolol, so the carbonic anhydrase inhibitors, and Combigan, which is brimonidine and timolol. Once again, the beta blocker combinations tend to be some of our most common combinations, although Simbrinza does contain brinzolamide and brimonidine for those that do have a beta blocker intolerance. So the advantages of a combination agents are certainly that it can reduce medication burden. That would probably lead to better staff adherence in terms of remembering to do just the one bottle and not forgetting any other bottles. with risks, it certainly combines the adverse profiles of both ingredients. So it's important to remember that when we're using these agents. This is just a systematic way of looking at some of these agents that we've talked about before and kind of just highlight the drug class, some of the ocular side effects, some of the systemic adverse side effects, and sort of the geriatric concerns that we should be monitoring for. And I've sent a copy of these slides to Dr. Palat, so that will be sent out later, so you don't have to take notes if you're taking notes. So let's talk about some of the implications. Why are we talking about this, and why is it relevant to patients in the nursing home? Because there's the risk of polypharmacy. There's a lot of drug-to-drug interactions, so it's really important to check these medication lists. For some of the patients, they may have some cognitive impairment, and therefore they might not be able to communicate the side effects of what they're feeling, how their eyes are feeling. And so being aware and monitoring how the patient's eyes look would be important. It is really, really important to talk about staff education in terms of how to administer a drop. For any of you who've tried to use eye drops, including myself, when I try to use it, it's really, really hard. It is not an easy task. So talking about what the steps are and how important it is very important. For example, the tip of the bottle cannot touch the patient's eye or their eyelashes or their eyelids. Any part of the patient that comes in contact with the tip of the bottle could lead to potential contamination. And so you want to avoid it as much as possible. The other things are there are physical limitations to our patients, even for those that may be allowed to use instill their own drops. They may have arthritis. It may be really hard to press on the bottle. It may be really hard for them to see where the bottle is and not stab themselves in the eye with the bottle. So these are things that we need to be mindful of, especially with these drops. Some of these bottles are really hard to press. And with the ongoing shortage of where the medications are being produced, we have very limited say in terms of what types of bottles or how rigid the bottle is for squeezing. So once again, to emphasize, it is really important to train the staff on any eye drop technique. So for example, the easiest way is probably to pull down on the lower lid, have the patient look up, and then put it right in that pocket where the eyelid, where the conjunctiva is, because that little pocket is where it can catch most of it. The eye can only hold one eye drop, so there's no need to drop 2 drops at a time, because the eye, even with 1 drop of the normal size, it's more than enough than what the eye can hold. The key to absorption is actually having the patient close that eye for at least 30 seconds, preferably 1 minute, before moving on to another agent or before moving on to the other eye. The other things are that you really want to make sure that you're not rushing in between drops. So we certainly don't want one drop to be washed out by another drop. So in this case, even though I said the absorption ideally would be 1 minute, maybe even waiting 5 minutes between drops. I certainly understand staff are very busy and they can't wait around like 30 minutes to just do 3 different eye drops. But I think even 2 or 3 minutes, if possible, would be sufficient time so that you're not washing out the first drop. It is important to also educate the staff on monitoring for changes in alertness for the staff. If they're noticing that the patient has increased falls, it may be due to an eye drop that they were started on for their glaucoma management, and certainly any respiratory symptoms or eye discomfort or redness. So what can we do moving forward? I think keeping that regular communication with ophthalmology or optometry to go over some of the concerns that is noted. It's important to document and certainly report adverse effects promptly, confirm an allergy history, especially with the sulfa agents, and individualized therapy for comorbidities and care needs are definitely a top priority. So with that, I conclude my talk. I'm happy to answer any questions if we do have some time. And then I did leave my email as well as a link to the QR code for my LinkedIn address for those that have any questions. Thank you.
Thank you. I learned a lot of things. I talk to you all the time about eyes, and I learned a lot just from your presentation. Thank you so much. What kind of questions do people have? Dr. Reitman, you have your hand up? Oh, you might need to unmute.
What's the role for surgery?
The role of surgery, I think, is uncontrolled IOP. Certainly, if the patient cannot tolerate a lot of the topical medications, I think certainly the patient has to be well enough for surgery, as most of our surgeries do require anesthesia. So there is some medical clearance that would be needed. I think in a setting where the patient can't really take care of themselves, but do have some help in terms of doing their medication, surgery might be okay. I think the downsides of surgery are that if you operate on a patient, it doesn't mean they're cured. It just means that the pressure may be controlled. The continued follow-ups are still very important.
Dr. Shepard,
Yeah, can you hear me?
we can hear you.
Yeah, so I sometimes see patients on steroid eye drops long term, and it always makes me a little nervous. And because I think that can actually cause glaucoma, right? And what conditions should I be aware of where a person might be on long term steroid eye drops, and how do I monitor that?
Yeah. I think steroid eye drops, especially for those that have corneal transplants, is probably the number one condition that where I see steroid eye drops just prescribed long term. Not all glaucoma patients are steroid responsive. However, there has been documented cases, and it is an important thing that if a patient is a steroid responder, their intraocular pressure could be really high. I think if they're on once a day steroid, it's fairly safe. It's probably just to maintain that corneal transplant so that it doesn't fail and they won't need another corneal transplant. But in terms of like a lot of steroids, the only other condition where we commonly prescribe steroids is in the case of uveitis. However, we do not tend to prescribe long-term topical steroids because we may need to consult with the rheumatologist, sort of finding out the underlying cause for that inflammation and not just be on, every 2 hours of steroids. I think if you're noticing that the patient is on a lot of steroids, and what I mean by a lot is like 4 times a day, just routinely, that is always something to ask, like, oh, is there a need? Maybe if they're undergoing or recovering from acute surgery, we do tend to put them on steroids for a few weeks, but we tend to taper them down. We don't put them on it. However, I have seen patients where, somehow in the transition process of, having had the surgery, but then moved to a nursing home, and somehow somebody forgot to stop the steroids and they're just on steroids for 4 times a day with no apparent reason for why that's the cause. And it was probably because perhaps they didn't have that further follow-up to say, hey, these steroids need to be tapered off and eventually we need to stop them. But there are a number of conditions that patients do get started on steroids because of either surgery or systemic inflammatory disease that causes them to need topical steroids. But I think whenever in doubt, perhaps reaching out to the prescriber of the steroids would be important and having that conversation.
Thank you. Dr. Muller is asking, when the patient is at end of life, when can glaucoma meds be safely stopped?
So glaucoma is it tends to be a fairly slow disease progression unless you're having a really high intraocular pressure spike. In a patient that has been fairly well controlled on glaucoma drops and it's the end of life, I would stop the medication personally as a glaucoma specialist. I would really have that long conversation with the caretakers as to what their goals are. Because even if the pressure goes up, as long as they're not in pain, I would stop the medication. Because if it's fairly short life, these drops can be the ache of most of my patients that I see. A lot of patients tell me they're so uncomfortable. It's really, it makes my dry eyes worse. I'm really uncomfortable. And perhaps that's when we think about other interventions like lasers or surgeries or, intracameral ways of engaging these agents.
I think there might be some different perceptions of what a short lifespan is. Are you thinking people can stop them safely if the lifespan is weeks or months or like a year?
I think it depends on the degree of disease. So in a patient that has very mild glaucoma, who's on maybe 2 agents, but with pretty well preserved optic nerves and off of medication, their pressures are like 30 or so, it may be okay. But for someone who has, just that tunnel vision left, we're talking about a few neurons of the optic nerve that's left. So those pressure fluctuations would matter more. So if they have pretty good central vision, but their peripheral vision is mostly gone, that becomes very tricky because it does involve well, how long is long, end of life? How long is that end of life? And it's hard to predict. And so it's kind of that discussion with either the guardian or other family members that sort of helps to decide. And you could always do a taper off of it, see how they do, and you can bring them back and see how they're doing, right? It doesn't mean, once they're off of it, we never see them again. So I think if you're concerned or you want to do a trial, you can always see what their glaucoma or what their intraocular pressure is off of medication and how much IOP lowering are we talking about here.
Are there other questions? Oh, Dr. Reddy is asking, what is a safe taper regimen?
With regards to glaucoma medications or?
Yeah, let's say someone's on some eye drops once a night, one of those once daily dosing.
Yes.
And you're
well, a lot of my patients have not seen their eye doctor. They might be like in their late 80s or 90s, and they haven't gone back to see their specialist in years. And they just want to be conservative and they want to decrease their medication regimen. They want to take less and they don't really know whether, it's really helping them anymore, or if they want to stay on everything that they have. What would be my safe taper regimen at that point to see if they even need it anymore or not?
I do think that these would still need to be monitored in some way, because unless you're checking an intraocular pressure, it's really hard to know what is happening. And once again, if they haven't seen anyone to kind of assess their optic nerve function or what it looks like, it's hard to then make that recommendation of how to taper. And I think that is where optometry or ophthalmology would come in to be the ones that do the taper, rather than for geriatricians to have tapering them off of their glaucoma drops or other agents.
Yeah, that's what's confusing here, is that sometimes I find patients who are there and they've just been on these long-term chronic steroids for just years, and nobody really knows who's monitoring, or they've never been back to actually have an exam. And it's just hard to understand, what was the plan? Were you supposed to be on this forever? Or was it really only for pure glaucoma versus was there actual uveitis or what? And a lot of times people don't really have answers or question, we don't really know what the indication was.
Yeah, the only concerns about that is, without getting someone who's familiar with the eye involved, is that, if it is a corneal transplant and you decide to taper them off of their steroid, then they have a rejection of that corneal transplant, and then they're in pain, they can't see. Now they're needing another corneal transplant, and they're not really able to go through another procedure, right? So, and it's hard to predict, when does the cornea transplant starts failing. So I still think, for ophthalmology, it is really about the exam. Oftentimes, I think most of what we do is based on what we see and how the cornea appears. It's not a descriptive diagnosis where, we can talk about it and like how they feel. It's more so like we just have to see it. So finding ways to be able to, take a picture of it, or, with the new devices that are coming out, portable cameras, perhaps that would be a way to assess remotely.
Yeah. Thank you so much.
One more question from Dr. Reitman. Is eye pain common with glaucoma?
It depends on what type of glaucoma. I think for acute angle closure glaucoma, or where the eye pressure rises in a small window, it can be very painful. So you may have symptoms of vomiting. You might see halos around lights, and that's usually emergency. However, long-term glaucoma, where the pressure is slowly building up, patients don't know. Oftentimes, glaucoma is one of the most underdiagnosed diseases, because patients don't come in until it's really late, until they're like, I can only see this tunnel. I've been noticing that for a couple of years, but I've never, my eye doesn't hurt, so I never came in. And you're seeing that, the optic nerve at that point is almost completely gone. And so that's why the importance of a screening eye exam or routine eye exam is really important.
Appreciate that. Thank you for your presentation, and thanks for taking our questions. Loved having your expertise on today's call. Well, we have some time. I will go on to our next presentation. Okay, and so I'm Palat, president of CMBA Palat MD Colorado, and I'm talking today about microtransitions, best practices for seamless transfers of care. Microtransitions are the temporary transfers in custodial care that are non-urgent in nature, yet carry a similar risk as major transitions of care. When patients make major transitions, like they go to or from the hospital, or they get admitted to our communities, we're usually on the lookout. We're watching for delirium, we're watching for iatrogenic infections and changes in their medications and orders, just to name a few. And sometimes we're even required to write a new H&P when those major transitions occur. But microtransitions are associated with similar impacts. A patient might go out to see a specialist, like their ophthalmologist in the clinic, or they might go out for an outpatient procedure, and they might come back with new orders, with new diagnoses, a totally new plan of care. And even if our regulations don't require us to write a new H&P or to open a new MDS, we have to reconcile these changes. When people go out for non-medical reasons, like to visit their family or to have a recreational trip, their care is affected. We still need to prevent falls and manage incontinence. Sometimes people might go out to see an attorney and come back with a new power of attorney. There's nothing micro about that care, about that change. Sometimes a otherwise simple change in the patient's room could mean that they also have to change their caregivers. There's a new furniture set up in their room. They have a new roommate. Being on a new unit could mean new infection control precautions. The mishaps can happen, and these micro transitions, if those mishaps are not addressed, the micro transitions can result in a major transition, like an emergency department visit. Well, I had the opportunity to lead the development of some best practice recommendations on micro transitions with the Transitions of Care Committee through Palat MD. And along with Doctors Abel Green and Ben Cantor, we started a couple of years ago by compiling a group of experts. And many of these experts who joined our panel are actually from Colorado, and some of them are on the call today. Thank you, Jenny Albertson. Thank you, Leslie Eber. Appreciate you being on our panel. And I'm sharing their names because these people helped us respond to surveys. They joined a focus group. and they were able to answer questions about, based on their expert opinion, what are the best practices for microtransitions? Which ones are the most beneficial and would be most feasible in our communities? And we used a modified Delphi study method to organize the results, and they were published last December. So many of the clinically beneficial and feasible practices are highlighted here on this slide. And I'd like to introduce these themes for you. And I suggest that everyone on this call pick one or two of these to investigate in your facilities this coming week. Find out what the current practice is and see what you can do to make it better. So first and foremost, we need to ensure high quality communication. Who needs to know when a microtransition is happening and what kind of information needs to be transferred with that process? For example, your patients who are going to hemodialysis 3 times a week, what kind of information is going to dialysis and back from dialysis with them? Is it the information you want to be transferred? Next, we should think about adverse events. How can we anticipate and prevent them? If one of your patients is out on an outing and they need their PRN or albuterol, or they need their anti-seizure medications, are they going to get access to it? Or is that an automatic transfer to the emergency department? The purpose and destination of our outings matter. If a patient is being treated for C. diff, for instance, maybe that's not the best time for them to go watch a movie. On the other hand, same patient who goes out to see their infectious disease specialist, it might be very worth that trip. Appropriate equipment needs to be arranged, like glasses, hearing aids, wheelchairs. The environment needs to be considered. If the environment during a recreational trip involves sun exposure, I want my patients to have access to sunscreen. Ask me how I know that. And one final theme that we highlight is that the skill of the escort can make all the difference. Who is going with our patients on these outings, and what do they need to know? How are we involving the drivers? How are we preparing family members for outings? My favorite publication from 2025 is this perspective piece from JAMA Internal Medicine by Drs. Green and Cantor, and it's called A Mother's Goodbye, Barriers to Microtransitions in Care. Dr. Green is here with me. She is a geriatrician and medical director in Texas. And Abel's aunt resides in a nursing home. Last year, her aunt's daughter, so Abel's cousin, died. And so Abel offered to take her aunt to the funeral. And being a good nursing home doctor, she called the facility ahead of time, told them the date and time of this funeral, said that she needed some help getting her aunt ready for this outing. She shows up early on the day of, dressed to go to a funeral. Her aunt was still in bed. She had not been cleaned. They had gotten orders ahead of time to put in a temporary Foley catheter. Foley catheter hadn't been placed. She had to scramble to get her aunt ready to go out. The van was late. The wheelchair didn't fit in the van when they finally got out there. And after all these things happening, they ended up not going to the funeral. And in this article, Dr. Green reflects on how there was just no protocol and also no sense of urgency to help get her aunt out of the building. It was a very different experience compared to transferring one of her own patients to the hospital. And yet, for this woman, attending her daughter's funeral would have meant so much more than any trip to the hospital. So does your facility have good practices to create seamless microtransitions? My call to action is that each of us find at least one piece of microtransitions to investigate in our facilities this week and try to do something to make them better. If you don't have access to JAMA, let me know, and I'm happy to send you my copy of that article or any of the articles on this reference list. Thank you. Any questions about microtransitions? Thank you, Dr. Eber. All right, I think we have just a few moments left. Dr. Reddy, are you available to tell us about membership with PulpMed Colorado? Dr. Vikas Reddy.
Yes, the worst half. But no, thank you guys for joining and thank you for that presentation. I think communication of any sort is very important and vital. And it definitely takes kind of a village and a community to take care of all these residents. But I wanted to spend a few seconds just talking about our annual conference. It'll be our 31st annual conference for PulpMed Colorado. It'll be held at the PPA Event Center on April 24th. And we look forward to having as many of you guys, there as possible. We've been meeting and aligning a good roster of presentations that we think will be beneficial for everybody. And while you guys are registering for that, we also wanted to highlight the registration for CMDA for PulpMed Colorado. I'm still struggling with the name change as well. And you get a discount, so it includes a discount to the annual conference. It also helps with the advocacy, the education that not only do we present here for the annual conference, but also helping kind of get gear in the new generation of the future leaders to sponsor them as well. And also try to have more networking opportunities. So we hope you guys join. We hope to see you guys at the annual conference as well. And happy holidays, everybody.
And this year, we really want to try to boost our membership. And as part of that effort, if you come to the conference and you are a member, there will be a special designation on the name tag for members. And we usually have a dinner the night before the conference to celebrate our speakers. And this year, we would like to invite members of PulpMed Colorado to join that special dinner. So please sign up and follow Dr. Reddy's example. Appreciate it. Well, have a good afternoon, everyone. Thank you for joining our monthly meeting. We'll see you again in February. There's not going to be a separate journal club later this week. Thank you.
Thanks, Zhang.
Yeah, thanks, Leslie. Glad to see you.
Nice to see everybody.